Welcome, everyone. I'm Dr. Erica Trappel, and I'm the Director of the Prevention Research Center for Healthy Neighborhoods. And I am very excited to welcome you to our January research seminar presented by Dr. Jane G. on social risk factors and unmet needs in the clinical setting for multi-ethnic and linguistically diverse populations. If you haven't been with us before, we encourage you to connect with us. You can follow us on Twitter at PRCHN, on Facebook, and we always post our seminars to our YouTube channel after we, within a week after we record them. We also like to highlight our upcoming seminar at the start of each one, and we'll put the link in the chat. But for the February seminar on February, whoop, lost my share, just a second. Okay. For our February seminar, we'll be welcoming Dr. Jessica Cook-Bailey, who is an assistant professor in the Department of Population and Quantitative Health Sciences here at Case Western Reserve, who will present on her work, All Eyes on Us, a community-based perspectives on eye health and vision care in Cleveland. And it will highlight the importance of team science and community-engaged research for health and genetic studies by discussing successes, barriers, and challenges and lessons learned from this study. I got to be a part of this, and I'm very excited for Dr. Cook-Bailey and her team to present the results next month. Bree will be putting the link to register into our chat box, so please feel free to register through the link. As always, while we are still virtual, we miss the opportunity to connect in person, so we encourage you to connect through the chat and add your name and organization to the chat today to introduce yourself to others that are joining the call. And we will use the chat feature today to type in questions during our presentation. And so now I am very excited to introduce Dr. Jane G., who is here with us today, joining us from San Francisco. Dr. G is a practicing general internist and investigator in the Division of General Internal Medicine at the University of California, San Francisco, where she's an associate professor of medicine. Her extramurally supported research program aims to reduce health disparities and promote health equity among multi-ethnic and linguistically diverse adults by developing and evaluating innovative patient-centered interventions in primary care. Her current research focuses on the influence of contextual factors such as race, ethnicity, language, culture, and health behaviors on chronic disease self-management, particularly among patients with multiple chronic conditions, as well as patient-provider communication about contextual factors with a particular interest in unmet health-related social needs, and use of photos as a tool to communicate about contextual factors important in chronic disease self-management. Dr. G is also co-director of the UCSF Multi-Ethnic Health Equity Research Center and research director of the Asian American Research Center on Health. She received her MD and MPH in epidemiology from the University of Illinois at Chicago and completed an internal medicine residency at the University of Chicago Medicine with additional research training at UCSF. I am very excited, and this is one of the benefits of our virtual seminar, to invite Dr. G to present her work with us today. So I'll go ahead and stop sharing and welcome you to begin. Thank you. I think you're still on mute.
You would think after like 2.5 years on Zoom, I would figure out how to unmute. But can you see my slides and hear me now?
Everything's great.
Okay, great. Well, thank you so much for the invitation to speak today. And I'm going to talk to you today about social risk factors and unmet needs in the clinical setting for multi-ethnic and linguistically diverse populations. I'm going to start off and talk a little bit about my context to share a little bit of a story for today's talk. And so even though now I live in San Francisco, you can see I did all my training in Chicago. So I'm originally from the Midwest, Illinois, to be exact. So having grown up in the Chicago area, I like to say I can handle my cold weather, but it definitely does, you definitely lose that ability after you've lived in California some time. But growing up in Illinois, my parents were immigrants to this country. So early in my childhood, I was a beneficiary of the Special Supplemental Nutrition Program for Women, Infants, and Children, the WIC program, to support my nutrition as a baby and an infant and as a preschooler. And at the time, my parents did not have a reliable vehicle, so we always used the subway train here, that's viewed here, as our main form of transportation. But whenever I got sick or had to go to the doctor, this was oftentimes a struggle, because I remember in the middle of the night, my parents had to figure out how to get me to the emergency room or wherever they needed to get me to be seen. And now, as a practicing general internist, as a primary care physician for adults, I often learn about the contexts in which my patients live and try to manage their illnesses. And so for a subset or so, here you can see on your left, for many of those that are of Asian ethnicity or Asian that are mistaken for being Chinese, there's been a fear of personal safety in their neighborhoods with the rise of anti-Asian violence and rhetoric in our country, especially during the pandemic. And for some, of our patients that we care for, they're grappling with homelessness or housing instability or poor housing conditions with mold, pests, or inadequate heating, especially during the winter. And even more so, I think now during the pandemic, it's managing food insecurity in the context of trying to take care of the diabetes and the high blood pressure and their congestive heart failure, a need that's even become more apparent over the last 2 years that's overwhelmed the food security safety net here in San Francisco. And so I wanted to clarify about the definitions of what we're talking about today. And so first, social risk factors are the adverse social conditions associated with poor health. And as an example I shared about in my childhood and for the patients that I care for, common social risk factors include food insecurity, housing instability, transportation barriers, to health appointments, or even essential day-to-day activities and social isolation. Additional social risk factors include interpersonal safety, utility health needs, and financial strain. And so social needs are unmet social needs that affect health for an individual patient. So using myself as an example, the potential social needs that I had were food insecurity that was alleviated by WIC and transportation barriers to health-related appointments. And I wanted to clarify this because oftentimes we refer to the social risk factors and social needs as social determinants of health. But really, social determinants of health are the broader systems and structures that shape society. They're the conditions in which we are born into, live, grow up, age, and the wider set of forces that shape the conditions of our daily life, such as the economic policies and systems, our social community contexts, our neighborhood and built environments, as well as our political and social systems. So for today, we'll focus more on social risk factors and social needs and how these concerns might be brought forth within the clinical setting, specifically adult primary care, which is where we practice and do our work. Briefly, I wanted to just illustrate this hierarchy or the different terminologies that are used in this area of work. And I like this figure that comes from a blog at Health Affairs that provides a schematic to illustrate these concepts. So broadly, the SDOH, the social determinant of health, is economic stability, which supports policies that promote housing stability and food security. And the next is what we screen for in clinical settings or in whatever setting that you practice in, which is for food and housing insecurity, which we can use validated questionnaires to do so. And the next is having a need, because not everyone that you screen for food and housing security will have so. So having a need is when those needs are identified and then being addressed by multidisciplinary teams, including social workers, medical legal partnerships that may need help that can assist with completing governmental applications for assistance, and also collaboration with community-based organizations to provide needed support and resources. And I want to reference, for those that are somewhat familiar with this area, is the National Academies of Science and Engineering Medicine, which published a white report on recommendations for social care, which encompasses social risk factor identification and addressing social needs. So in part of their report, they share 5 A's of social care that can improve overall health: awareness, adjustment, assistance, alignment, and advocacy. So awareness activities are really the ways in which we identify social risks and assets of patients and communities. The next are adjustment, which we alter the way we deliver care to accommodate these barriers. Assistance activities are the way we connect patients to resources to reduce that social risk. Alignment activities, are where health systems understand what the assets are within the community, facilitate synergies, and invest into these communities so they can positively help affect health incomes. And lastly, advocacy are collaborations with healthcare, social service, and other types of organizations to promote policies that alleviate and address social needs. And so I would say for today's talk, we'll focus a lot more on the first 3 A's as opposed to the last 2 A's, because I think the last 2 A's are much harder to attain and are really works in progress. And so the key stakeholders, given the work that the center does, key stakeholders are essentially important in this work that we do in terms of identifying social risk and addressing social needs. So first and foremost are the patients and their families and caregivers, in which I think oftentimes when we're trying to design interventions, that their perspective must not be ignored and are really central to redesigning healthcare delivery to encompass social care. The next are the different facets of healthcare delivery. So I would view this as interprofessional healthcare teams, not only nurses, nurse practitioners, physicians like myself, but also social workers, community health workers, navigators, caregivers, personal aides, case managers, lawyers. They're all really part of the team to help address some of the very complex social needs, oftentimes more than one that our patients experience. Next, I think this is probably the most challenging aspect about this area is the healthcare financing structures, making the numbers add up. And it has to be really aligned and make sense, make a persuasive argument for healthcare systems to really pursue this type of work. And I would say now in this certain climate, there's substantial barriers to effectively integrate social care right now. And this is not multiple levels, so on the federal, state, and institutional levels. And the next, I think, because a lot of healthcare has shifted to incorporating technology, including when you are seen by a healthcare system, electronic health records, is that they need to be designed to support, identify, and address healthcare social needs. Some of my colleagues are using certain apps that interface with electronic health records to help screen, identify some of this information that could impact social care. And last but not least, community-based organizations and neighborhood-based assets and strengths are essential stakeholders so we can deploy resources to address needs and redesign healthcare that really leverages community resources and strengths to address some of these needs. And so I'll start off by talking a little bit about awareness. And so maybe you've heard what I've shared and you're thinking, oh, this makes so much sense for healthcare systems to do so, because we know social risk and needs affect how we care for ourselves and our health and well-being. But quite honestly, this is really an emerging aspect of clinical care for many healthcare systems. And where should awareness identification of social risk needs begin? Should it be in ambulatory care, where they're seen in primary care, or for their specialist, for their cardiac condition, or for cancer? Should be the emergency room, in which you might only have one touch to the healthcare system coming in for an acute illness or an emergency? Or should it be inpatient care, where you're there oftentimes for multiple days for an acute exacerbation for chronic issue or for an emergency? And so I'll spend most of the time today that I talk about on ambulatory care, as that's where I practice and done most of my work. But I'll add to the discussion that we'll always focus on adult social care in our conversation, whereas I feel like in pediatric social care as a parent, that they're in some ways, they're further ahead, where they've really thought about these things and some of it's already embedded in clinical practice. And so the learning health system for the work that I'll be sharing today, focused on social risk and needs, is the practice where I see patients. So it's the UCSF Division of General Internal Medicine practice that's based at 3 separate sites that are co-located in Lower Pacific Heights in San Francisco neighborhood. And we serve over 27,000 patients, about half are female, a third are age 65 and above, and it's very racial, ethnically diverse, which may not reflect the different communities in which you work. So it's 25% Asian, with Chinese being the dominant Asian ethnicity, 10% Latinx, 9% Black African American. And of our patient population, 9% have a non-English language preference, with the major languages being Cantonese and Mandarin, followed by Spanish. In terms of our payer mix, about 46% are Medicare and Medicaid, and the rest are self-private or self-pay. So this is not a concierge practice. This is a urban medical practice where I would see a startup founder and for one visit, and the next day see a patient that's experiencing homelessness. And we're also a patient-centered medical home, and we have clinicians that are faculty members, nurse practitioners, and also trainee physicians in our practice. And so in 2019, pre-pandemic, which now we realize was gives us a lot of good baseline data, we piloted social risk screening in the clinic waiting rooms. And they have visits that same day. So we offer them paper or online surveys for these social risk domains: food insecurity, housing instability, transportation problems, utility health needs, interpersonal safety, financial strain, social isolation, and functional abilities in terms of ADLs and IADLs. And so for food insecurity, we used the hunger vital sign, which was 2 questions and been validated. And for housing instability, we not only assess their perceptions of having a home and concern of losing their home, also the housing conditions, if there was any pests, mold, water leaks, and such. And these first 5 domains that I mentioned here are part of the Center for Medicare and Medicaid Center for their screening tool that they did for the accountable healthcare communities. So there were studies underway that were doing demonstration studies to look at the implementation of these questions. And based on our practice, we elected to add 3 additional questions. So 1 on financial strain, and then 2 questions, 1 each on social isolation, ADL. So there's a total of 13 questions that we offered in 3 languages in the clinic waiting rooms in 2019. And these were anonymous surveys. So only things we additionally asked were age, sex, and the zip code of their residence. And we also had open space for their comments. And each participant received a $5 gift card, and we offered them a printed resource guide in all the health-related social needs covered in the survey, available in each of the 3 languages. And so in terms of the study population, we recruited 679 individual respondents. And generally for the study, they tended to be older, a little bit more female, and then we oversampled for Chinese and Spanish speakers to get sufficient numbers for analysis. And here, this is somewhat of a busy graph, but it's organized by prevalence of unmet health-related social needs. So you can see to your left, the most prevalent related need was housing, where about 10% had some form of housing instability, and another 27% had a housing condition issue. The next was financial strain, followed by food insecurity, in which about one in four patients had food insecurity. The less prevalent needs here you can see were IADLs, transportation issues, and least common was interpersonal violence. And I think very strikingly in this population of patients, or I said about half were private insurance, that over half here had at least one unmet health-related need. And here in the next series of figures, we'll break down these needs by looking by gender, followed by age, and then survey language. And so here by sex, you can see that there were differences by sex, where female respondents had more significantly greater, at least one unmet need, financial strain, as well as food insecurity and other domains as well here, notably also interpersonal violence. And when you look by age, less than 65, over 65, there are also significant differences. And I want to make this note because I feel that oftentimes the services that are available are really for older adults that qualify their age 65 and above. And in our practice, a significant number of patients less than 65 had notable social needs. So they had at least one unmet need they had a higher prevalence of that compared to those that were older, as well as financial strain and housing problems. And so that I think speaks to the working poor, where in San Francisco, the cost of living, the Bay Area, the cost of living is so high that the salaries, which generates a lot of health-related social needs. Lastly, we looked at unmet health-related social need by survey language, and the Spanish speakers that complete the survey in Spanish were in orange, and those that complete the survey in Chinese are in, a gray-blue. And so we found that respondents that had taken the survey in Spanish had more prevalent food insecurity, 48% compared to the other groups, and needing support with ADLs, 37%, as well as transportation issues compared to the other groups. And what we learned, and I think there's some hesitancy sometimes for healthcare systems to be like, oh, we should do this. Maybe patients don't want to tell us. And overwhelmingly, we found that we received a positive response. And the themes, as you can see here in the quotes, was that there was concern for others, but wanting to internally recognizing that there was these concerns, and recognizing that the healthcare system could be part of the solution in addressing some of these health-related social needs. We also received a lot of stories about participants having experienced health-related social needs and gratitude for their certain situations where they had navigated their way out of that or overcoming them at some time. Or some actually describe their current experiences and narratives experiencing social needs as a barrier to attain health. And I'll note that there were no comments that directly conveyed concern or dissatisfaction with health-related social needs. So I think for our practice, this was compelling evidence that it was okay to go ahead and pursue this on a greater level. And so because based on these findings and the broader mission of our clinic to promote health and social justice, our practice and faculty decided to adjust our practice to address food insecurity, where 1 in 4 of our patients experienced it. So we examined this data by looking also by geospatial mapping. So the black star you can see in the middle there in zip code 94115 is where our clinic is located. And if you've looked at these sort of geospatial graphs, the darker orange color indicates a higher prevalence of food security among the respondents that reported that zip code. And then we interposed data from food deserts from the USDA, which is implied in the blue font. And you can see in the 3 major locations that had darker orange, they also were considered food deserts. And so this illustrates to us that our data also reflected some of the national data that was there, and using this population data could be a way to reach out and target patients that are at greatest risk. And so we created a food pharmacy pre-pandemic that addressed food insecurity as a social justice issue. And so this was a committee within our division focused on social justice, policy, advocacy, and community engagement. So we sought to offer assistance to our patients experiencing food insecurity with a weekly farmers market style food pantry that was held on site at our clinic once a week. And so this was done in collaboration with the local food bank as well as the Department of Public Health, funded by a private grant. And at the time of initiation, and it still continues today, this was not a system level intervention. It was really a clinic level intervention where clinicians and staff used the 100 vital sign to identify patients that could be at risk or patients self-referred to the food pharmacy. So say in the first 6 months, we had over 240 enrollees and distributed over 800 bags of food. But then we paused when the pandemic started because we were unclear what to do. But generally, the response was overwhelming. And I think, there's something to be said as a clinician seeing patients and understanding that they're grappling with food insecurity. And instead of just giving them a list of resources to call or to navigate, that you could provide them food that day. And the food was nutritious and healthy and could, not exacerbate potentially their chronic condition. So during the COVID pandemic, we had to sort of reimagine this given the constraints that were in place and also concerns for everyone's health and safety. So we prepackaged the bags of food that we purchased actually from a local wholesaler because the food bank had such an overwhelming need that they had to meet that the partnerships that they had with other organizations could no longer continue. So we created these bags of food of different foods, and then did also limited home deliveries for patients that were mostly homebound. And I would say, because our population is racial, ethnically very diverse, we made efforts to tailor the types of food to meet the needs and preferences of our patients. So often rotating into the mix, we include Asian vegetables like bok choy and dry goods like noodles into the mix as different sort of foods that would be available to them. And then we also had bags of emergency food, non-perishable food available for patients that were not able to attend the food pharmacy to give on an as-needed basis. And through this process, we also found that there was challenges with transportation. So we provided public transit tokens for them to travel to and from the food pharmacy. So in terms of last year, I just want to toot our horn a little bit. The food pharmacy distributed over 1,180 bags of food, and 81% of the patients receiving the food pharmacy often ran out of food, which is, as many of you know, our indicator of food insecurity. And this was a population that had significant chronic disease burden, and 73% rated their health as fair or poor. And 65% of them were using CalFresh, which is which is our version of SNAP or food stamps here in California. which suggests that the existing resources that are already available are insufficient to meet the needs of the patients, maybe in terms of the amount of money or in the types of foods that they were offered. And concurrently, we've been trying to address another issue within our practice, which was transportation barriers and how patients travel for their day-to-day activities, including medical care. And I will say, our ability to address this concern was really an alignment between health system leadership and clinicians, and really the bottom line about fiscal factors. Because about 11% have reported transportation barriers, and this seemed to track along with a 13% no-show rate at the time in which the data was collected. And so we were able to get buy-in from administrative nursing and medical clinic directors to test the impact of a potential taxi voucher program. Specifically, we wanted to see if we increased access to transportation, such as providing a taxi voucher for them to come to the visit and to return home, with this decreased no-show rates. And I'll add, using the language from the NAM, the 5 A's, during the pandemic, there's already been adjustments made because in some ways we were increasing access to clinical care by doing more telehealth visits, both video and telephone. So for those with transportation barriers, potentially greater access to televisits was really alleviating that concern. So what we found. So I worked together with the Director of Quality and Clinical Innovation, and we put together a quick and simple pilot RCT of patients that had a higher no-show rate based on what we could tell in the electronic health record. And then we randomized them to armed intervention comparison. And so the intervention arm received a mail reminder letter of their upcoming visit, and then a taxi voucher that we provided from a local taxi company with an explanation in the letter about what the taxi voucher was about. And they were told that if they came to the clinic visit, they were eligible to receive a return taxi voucher to go home after their visit. And the comparison group only received a mail reminder letter of the upcoming clinic visit. And we mailed them about 7 to 10 days in advance of their visits. And so you can see I didn't really share any of the quantitative results because we didn't really find any significant difference between the two groups. And only 2 individuals in the intervention group actually used a taxi voucher. So we called the patients and wanted to figure out what was going on. And so maybe not surprisingly, many of those that had received the taxi voucher by mail were suspicious because even though we tried to explain the letter, they hadn't expected their doctor's office to mail them a taxi voucher, and they were not sure what to do with it. But we also did learn that those that actually had transportation barriers, those that, we did the quick screening of the transportation barriers question during these calls. We found that those that screened positive would have wanted a taxi voucher. And many of the reasons for not showing up for a visit, because we called a mixture of patients that had come to their visits and had not, included not feeling well or work schedule changes, which would not be addressable by providing a taxi voucher. So now we've really pivoted to piloting universal screening for transportation barriers at one site of the clinic to identify patients that have transportation barriers, and then those that have transportations and also have a high no-show rate. We're going to try repiloting the intervention to see if in this population that has a greater need, would taxi vouchers sort of address the no-show rate. And so in this juncture, I wanted to pivot a little bit and talk about how else can we learn about social needs in the clinical setting, and what are ways that we can learn and communicate about these needs that oftentimes can be sensitive to discuss or difficult to elicit, especially in a short period of time. And so some of my work has focused looking at the role of photos as a communication tool for patients and clinicians in primary care. In one of my studies, we looked at patient-generated photos in the context of food insecurity and multimorbidity, which now is the most common chronic condition, having 2 or more chronic conditions. So why photos? So I would say first, as the saying goes, a picture is worth 1,000 words. Sort of like looking, when you're surfing the web and looking at CNN.com with photo galleries or photo stories, or stories of other parts of the world through the National Geographic, which I did often as a child, that photos can communicate so much. And next, most of us in our regular day-to-day lives are already using photos to communicate thoughts, emotions, and experiences. And so maybe today you'll have already checked Instagram or Twitter, or by texting photos to your family and friends. And then, during the holiday season, receiving or giving holiday cards with photos of loved ones included. And lastly, there's a lot that we can learn about how photos could be incorporated as a communication tool and in the clinical setting. because community-based participatory research has long used photo voice, a participatory empowerment methodology to promote social change. So this was pioneered by a social scientist at University of Michigan who conducted work in rural China. And it was an approach that can empower women who had lower social standing in their community to communicate their needs and experiences in an effort towards social and community change. And so photo voice, for those who are not familiar, I would posit is really a person-centered approach. And this methodology includes 2 steps, where participants take photos to capture aspects of their lives and experiences in their environment. And 2, they use the photos to share to others to stimulate reflection and communication about what's important to them and their experiences. And this methodology has been particularly valuable among limited English proficient populations and vulnerable populations, where oftentimes it can be difficult to share nuanced experiences and perspectives through typical communication strategies. And those are my children. And so in terms of the study design for this project, we recruited patients that were older, 60 or above, that spoke 1 of 3 languages and had at least 2 chronic conditions from the Alex-Hauser Comorbidity Index. And this population experienced food insecurity, scoring 1 or higher on the Adult Food Security Survey module. 1 indicating at least marginal food security, if not food insecurity. And they were able to use a disposable camera or a smartphone, tablet, digital camera, and then were active patient within the study site for the last 12 months. And so we met with them briefly to teach them about the photo taking sessions and also to troubleshoot how to take photos with whichever device they had chosen to participate in the study. And with photo voice, we gave them a prompt to take photos over the course of about 10-14 days. And this prompt was, what aspects of your everyday life affect what you eat and how much you have to eat? And we encouraged them to take 1 to 2 photos a day over a 10-14 day period, which culminated in the photo interview guide. And so the next slide, I'll share a couple of their narratives to give you a flavor to see what we learned. And so for this participant, this is the photo that they took. This is what I got from Super Safe. That was what I was able to carry on the bus. And my money was low, so I tried to get something that would stretch. You know, because you can make a soup and have some crackers and honey buns like for dessert. The sugar was maybe for the tea. Does that have some popcorn there? I think it's stuff that swells in our stomach to fill you up. An interviewer said, you said that your money was low when you went, right? Participant replied, yes. And that was around the end of the month. It was like, well, I think it was like 2 weeks. I had to take what I had to make it stretch. So we ate less. For this next participant, this is their narrative. This is a picture that they took of soup. And said, oh, that's soup. That was at the end of the month too. That's top ramen with green onion, and I had some chicken in the oven. That's another way I stretch stuff. I did 4 short thighs in the oven. I ate rice, the salad and stuff, and chicken vegetables, green beans and stuff, and mixed vegetables. And then I think I had 1 piece left. I cut it, chopped it up, and boiled noodles and make a meal so I wouldn't be hungry. I'm stretching because usually I don't use this stuff at night. I only use it in the morning. So I know I didn't have nothing if I made my own soup. That means I was trying to stretch. That's what I said, even if I had, like last night, I had a peanut butter and jelly. My glucose was like 157 or something. And I said, what did I eat? And then I said, oh, earlier in the day, I had half a bear claw. I said, oh, that was something sweet. That's why I had to take the insulin, and that's why it's high. Do you have to take more insulin towards the end of the month, would you say? And yes. Speaking to having to choose foods that are less nutritious, but calorie dense, that require more insulin. And what we learned through this process is that not only did we learn a lot about food insecurity and their dietary habits, we were able to learn more about the conditions in which they live, where our patients live. There's oftentimes, in our position where we see patients in the clinic, it's not possible unless we do a home visit to learn about their home environment, which can affect their health in so many ways, especially for an older adult. So you can see here on the picture on the left, this is a patient that talked a little bit about their narrative, their difficulty in not having a full kitchen in their living space, and using the kitchen where they used to brush their teeth to wash dishes, and how it was so shallow, and this presented a challenge in washing dishes. And to the photos of your right, this is a depiction of someone's living space in their food prep space. That you can see there was a full fridge, and then a countertop convection oven, but no stove. and so no facilities available. And I think when I first started learning more, I think we always knew that patient where they lived affected their health, but I think this really affects the type of things that you would recommend, because and where you come from a position of privilege, where not everyone will live in an environment where they can prepare food the way they want to, that to improve their health or to maintain their health. And so a few final thoughts that I had today, and I really welcome your dialogue and your questions, was that I think oftentimes we want healthcare systems to transform immediately and encompass something where it seems so obvious for us to address. And I would posit, say that the risk factors and unmet needs are there, even if you don't measure or see it. So that's what I would say to the healthcare system, is that, even if we're delaying on our end, our work to do something about it, they're still there. And so there needs to be a lot of concerted commitment, dialogue, financial commitment to do this on an institutional level, and on a national level. And in this talk, I've talked a little bit about the 5 A's that the NAM talks about. And to achieve optimal health and balanced health equity, we must be aware. So we have to screen at some degree, and also adjust the way we deliver clinical care and try to assist in clinical care. But I really think alignment and efficacy can be much harder. And I think it's because these are greater structural and financial commitments that take time. And I think UCSF, as an example, has taken some efforts to become and recognizing themselves as an anchor institution within San Francisco, as leveraging their economic power as well as their economic and intellectual resources to improve the health of the communities that live around here, seeking them for contracts, for catering, different types of needs with on campus, as well as hiring. And I think this is a movement that more institutions are moving to, but the changes I think being seen from there take longer and time to see. And I would consider, thinking about the new ways in which we can learn about what's important to patients, about how they live in their homes and their communities and their social needs, and how photos can be a way to help support that communication. And so some of the work that we're doing now is focused on this novel photo-based communication tool to address contextual factors that are important to current disease care. So not only dietary behaviors, potentially food insecurity, but also medication use, their home environment, as well as their fall risk, and then social support. And so I wanted to acknowledge the members of my team who helped make this work possible, as well as the funders for this work, both from the National Institute of Health and Foundation. And so I wanted to thank you so much for your attention and invitation to speak today, and I welcome your questions and comments. Thank you so much.
Thank you so much, Dr. G. And I welcome our guests to come on camera. And we can open up for conversations. You can feel free to take yourself off of mute or just leave your question in the chat box.
Question, if I may. Hi, Dr. G. Thank you so much for coming to our center. The photos were so powerful, and you're absolutely right that it says so much about people's lived experiences. And you did, the 5 A's were also such a helpful framework to think about. But what are your thoughts about using these photos to actually advocate for change in patients? And sort of, yes, it's hard, but sort of, what do you think could be the next steps in kind of achieving change or really intervening? Because now that we know folks live in these circumstances that are not optimal.
Well, thanks so much. Nice to see you again. I remember when we met in San Francisco. So, I think, we're undergoing efforts to publish this work in a scientific journal. But I think that's really just a drop in the bucket. I really think the large impact of work is to leverage the work of photo voice itself, right? To use this on a more public lay level to share sort of the stories of older adults that these things are affecting how they live their lives, they affect their chronic conditions, and really these inequities are so persistent across the board for many patients and many communities. I think that's really going to be the power. And I think that work is so much harder because, one, as someone that's in academia, that work is not compensated, right? And not that we wouldn't do it, but there's just not a lot community engaged work is not compensated in that way. It's sort of flip-flopped, right? You need to get the grant to compensate the people to do the work with you, but to do the work, you need to invest that time and energy to really work with those community partners. And so I think that's a significant barrier to thinking about it beyond that. And I think, the pandemic and all these things that have already occurred have brought some of these concepts to light. But you can see our national dialogue and discourse with so many experts and people that are very well intentioned that we haven't made a lot of significant inroads. So I'm hopeful that we can figure out ways across the nation, like we're talking today, to work together to address them. And personally for me, I think in San Francisco, it's really building those connections with people with their boots on the ground. They're really occupied now with the acute fires that come up every single day related to the pandemic and acute needs of their community members. I think the broader scope will be to build those collaborations to address this on a broader level.
I've been monitoring the chat and there are a few questions here. And Dr. Em asks a question that I've actually was thinking about as well. She said, "Thank you for sharing. It's fascinating and inspiring. I'm curious to learn what you identify as barriers to take these studies to sustainable and long-term resources for your patients." And I've also wondered the same thing. I think I saw you had some grant funding there, and I think we've done the same thing, is use some grant funding to get started, but then how do you conceptualize sustainability of those things?
I think, there's several things that we have in the pipeline. We've done, so initially that data that you see where we surveyed 679 patients, that was done with $30,000 grant, right? With a lot of students there. And then, during the time in which we were doing this work, our health system actually rolled out in our electronic health record a way to capture this data. But even though it was rolled out, there was not an institutional investment yet to really, throughout the healthcare system, screen patients for it and figure out a way to address. And I think one barrier here is, as I mentioned earlier in my talk, where there's this perception that, once we know, we have to do something. But even if you don't know, you don't even document it, it's still happening. So I think it's a balance between those two. So one thing that are happening with the University of California is at a University of California level with all our different sites, Riverside, Davis, San Francisco, Merced, there's efforts to really to purchase a sort of electronic health-related social need resource that can be deployed to patients. So I think that's sort of a simplified way where you identify someone that has a need and then you can offer them resources. And because I definitely, in our conversations with social workers throughout this work, is that we have one social worker for 27,000 patients that's allocated to us. She did not want to receive thousands of referrals from all the things that we were generating. And I think you have to kind of calibrate the degree of intervention, because some patients simply is giving them the information and then they're able to connect with it. And some patients need a little bit more high touch. And I think with the high touch, we can do more on in a clinic, institutional level, and leveraging sort of the alignment and the efficacy where we need to partner better with community organizations that know how to do this, that already have the structure and experience to do so. And I think there's inklings of that in the institution where I work, and I maybe perhaps elsewhere. But I think that's the way forward, where we need to not reinvent the wheel and think that us in academia have all the ways of solving this problem, because others have figured out better ways and more efficient ways to do so. And really the challenge is creating that partnership in the communities to do that.
Great. I'm going to jump around in the chat just to sort of weave a thread. Amy Schoen is here and asks, I know that UCSF has been a leader in consideration of digital skills and connectivity as the super social determinant. Amy, would you like to finish your comment? I just saw you turned your camera on.
Sure. Yeah, UCSF has really been a leader in the digital inclusion world and the connection to health. So I'm curious whether sort of broadband subscriptions were included as a utility that was assessed, or did you assess it in any other way?
So that's a great point. In the time in which we did the survey, we did not include that as a question. But I think moving forward, essentially, that would be a very important question to ask moving forward. We did see a lot of disparities in those that were able to access telehealth by video versus those that were not. And even though, I live in a neighborhood in San Francisco that has lower capacity for Wi-Fi. And so even when I was trying to see patients from home during the early stages of the pandemic, I would lose connection. So I definitely think this is, and there's been efforts with some of our faculty members that have been doing works to help patients be more connected, either through their home Wi-Fi or through the smartphone devices that they have to learn how to use them. And I think there should be more work in that sphere where we should have Wi-Fi. I think there's been talk on a national level where we should just make Wi-Fi like a public utility and everyone should have access to it, right? And we should just walk around and have access to it. So we did not include that in our work, but I definitely think that's important moving forward.
Thanks.
There are a couple of questions around your photo voice work. One saying, would you say you had difficulty in inviting some people to share their experiences through photo voice, or there subgroups that were reluctant to share?
We found that patients or participants were willing to share what they took photos about. And I think it's difficult to know what we don't know. So I think we took whatever they were willing to share. And I think, if we were able to extrapolate this and translate this into the clinical environment, and you were seeing someone that you had seen for a long time, that the photos that you present each time, you might learn more and more, sort of like uncovering like an onion. So I find it to be a more rich experience and a little bit less frightening, because I think sometimes when you're being asked to reflect or share something and then there's nothing for you to anchor on, you're just sort of like rambling or just talking and sharing what comes to mind. And I think a photo gives you something to anchor on and look together and learn a lot about a lot of different things. And our group has actually been developing a way of how do we systematically code photos that people have taken, so we can extract information, just like we do qualitative coding of interviews and abstracts. And I find that what we each think is the focus may be a little bit different, but we also notice a lot in the background, a lot of different things that otherwise you may not have noticed or seen. Just like going to a museum and looking at art, what you see and I see are very different. And so I think that's the power of the photos, where there's a lot of richness and we can see a lot of more things than just by talking.
Philip, I saw you turn your camera on and then off. I was going to go to your question next. I don't know if you'd like to ask it yourself.
Oh, I'm happy for you to do so. Thank you.
Oh, sure. So a related question says, are there ways to connect the photo voice and stories into your EHR? And is your EHR connected to partner organizations who can help address the unmet needs?
Oh, thanks so much, Philip, for the question. So my current work now is that we're trying to deploy this photo voice technique in the clinical setting. So we're doing the formative participatory design to design the intervention that will allow the clinical environment to support it. So I think it's already happening to some degree already, even without the intervention that we're describing, where patients now with the patient portal, they have it on their phone. They may be texting us pictures of their medication bottles or rashes or certain physical ailments. And so we're trying to figure out what is the optimal way for patients to share different photos about different things that are important to them. Because you can imagine during the pandemic, a lot of clinicians are receiving a lot of these patient portal messages about a variety of issues. So we're very sensitive to the fact that there's an eagerness for patients to share this information, but how do we share it in a way that doesn't overwhelm the clinicians and electronic health record, and how do we share it in a way that's actionable? And our EHR right now is connected with other partner hospitals that use the same EHR. But as I spoke to earlier, University of California is interested in contracting with a larger company that has resource guides or resources for different health needs, and to deploy that. And I think my understanding from that work is that we would not be UCSF would not be the initial site, but be a subsequent site in trying that program to address some of the milk needs. And I think that's essential because we cannot rely on social workers alone to do this, and there's not enough other team members in the interprofessional clinical teams to do this work. And I think we cannot ask, oftentimes as a physician, we do a lot of interventions that focus on physicians, and I honestly think physicians cannot take another thing on their plate to do and do all the other things they need to do well.
Thank you. Are there other questions? I have one, but I want to make sure I leave others an opportunity to ask first. Please feel free to take yourself off mute. I'll go ahead and ask mine while we wait for others to jump in. One of the challenges I would imagine, particularly in multimorbidities and chronic disease, is really moving those outcomes, right? And a lot of times there's a desire to say, how is this work in social determinants really moving on outcomes? And I'm wondering what sort of short-term, intermediate, and longer-term metrics you're looking at to sort of define success of the work that you're doing right now.
So I definitely think, as for funders, it definitely is health. It's their hard primary outcomes that they care about, clinical outcomes. So in some of our work, we look at patients that have type 2 diabetes, in which the hemoglobin A1C is a important outcome, and moving the A1C to a range that's more desirable is something we are intending to look at, but I would say is not the primary outcome, at least from my perspective. I think the primary outcome for patients is really to live an optimal quality of life and to perceive that the care they receive is centered around what's important to them. And so those, I think, are harder to measure, and they are different for each person. And I think those are probably the most important to learn about in populations that may speak different languages or come from different cultural or racial ethnic backgrounds. And so I think for us, those are, I think as a clinician, wanting to feel that the work that I'm doing, yes, that they're achieving their blood pressure or their A1C, but to know that we understand them and that we're helping them address the concerns that are important to them. And so for some of my patients, it's really being able to do X, Y, and Z with their family or maintaining their independence. And I think learning about what's most important to them can help us create a more actionable plan to do so. And I think, there is still benefit, obviously, to treat an A1C or blood pressure to goal, but sometimes that the cost of doing that is maybe at the cost of them attaining what's important to them. So I think it's a balance, and we're trying to navigate some of that now through the work that we're doing.
Thank you. Questions from our audience?
Can I ask another question?
Absolutely.
Thank you so much. About the transportation barriers that you showed in the social needs data. And to me, I think it was like 11%, but what I'm struck by is it seems like the patients were pretty resourceful because they arrived at the clinic and reported that they had transportation barriers, but they still got to the clinic. And I'm curious about sort of if there were any comments that folks left that could give, because you also showed the RCT data didn't show many differences, but were there any comments that you could have gleaned from those patients that may have had transportation barriers but still made it to the clinic that could help inform how to address that barrier in the next iteration?
I think, it's kind of like this catch-22 thing, right? You're trying to study transportation barriers, but you can't really speak to the population and, without them coming to clinic in some ways, because if you use the patient portal approach or telephone, there are their own barriers to that itself, right? So we did find that those that had transportation barriers became, often it was of a great combination of barriers, right? Like they had to wake up really early, pack up all their stuff, almost fell on their way there, almost missed their bus, and then had to walk, and then they were late, right? And so I think all those different challenges probably could be alleviated if there was other reliable forms of transportation like paratransit for some that might be available, and then potentially a taxi voucher. So I think, reasons why patients do not come to visits are really multifactorial. Transportation is maybe just a sliver of that. And I think for some patients that I think the pandemic has showed us, at least from my clinical perspective, is that not every patient needs to be seen in person every time. So I think it's really calibrating the way we care for patients is, when do we need to see them in person, and when, undergoing sort of that perilous trek to come into our clinic may be worthwhile, and when may be okay just to do a telephone call or a video visit. And I think we're all learning this real time, because before the pandemic, telehealth was really kind of just starting. And we were early, there were early adopters of it, and then it became like overnight, became like 90% of the work that we're doing. And I see there's a question.
Yes, there's a question. How can photo voice be used to promote clinician empathy towards vulnerable populations with preventable disease and limited resources?
I would say already, in sharing some of the photos that we've included in our work to clinicians, that the photos speak very loudly. So I think, there's a great deal of clinician burnout right now during the pandemic, just with the degree of complexity and the continuing ongoing high burden of disease. But but ultimately, I think clinicians are human beings too, and we relate to patients as human beings as well. And so I think the work that we're doing here is really getting back to basics. Unfortunately, our healthcare system has made things very transactional, right? Like I sent you a message, well, I need to respond, I need this, I need that, right? And then, doctors and clinicians get press gaining, like, Yelp reports about how they, how did they do, right? So I think photo voice can really use to humanize the work that we do again and bring it back to what it really is, two people talking to each other, and we're trying to help each other. And I think it seems like we're a little bit far away from that right now, because we're just trying to make through what's going on right now. But I truly think, this work was really difficult to get funded. It was very difficult to explain to National Institutes in Health that this was a worthwhile and meaningful, it took years to get funded. And so, but I think it's even more, and so I even believe in the work more now, because I think moving forward, when we see the other side, we're going to have to go back to relating to each other as human beings and understanding what's important to each other, and I think some of the most gratifying interactions I have as a primary care doctor is those I've taken care of for a long time, that I share some about my life and my children and what's going on with me. And to them, I think that makes what I'm saying as a doctor to them much more palatable, much more willing to accept or trust, and then to move forward together.
Thank you. Other questions? This has just been such a wonderful conversation. I'm so certain that everything you've shared has really resonated. It's certainly resonated with me, and I'm sure it's resonated with others on the call today. And I just want to thank you again, Dr. G, for being here and sharing your work. It resonated with me earlier when you made the comment of let's learn from each other across the country and find ways to do this, so that we're really making as much forward progress for all of our for our entire population, and sharing those lessons. So I hope we'll stay in touch. I want to thank everyone else for coming, and I would love it if you could take turn your cameras on just for briefly and give Dr. G a round of applause.
Thank you.
And it's nice to see that there are people on the other side. I know it's the hard part of doing virtual seminars, but we are all here. So thank you again. I wanted to remind everyone to please join us in February for Dr. Cook-Bailey's presentation. Bree has just posted the link to register in the chat box. We hope you'll be able to join us again. And thank you so much. Have a great afternoon.